Good morning, I'm Rienzi, and I'm very happy to be part of this very interesting meeting. I would like to thank the organizer for the invitation. So today I'm going to talk about PGT-A, principle, methods, and aims. These are my potential conflict of interest and nothing related to this presentation. So let's talk about PGT, Preimplantation genetic testing. What is the aim? The aim is to identify in the embryo or in the fertilized oocyte through polar body biopsy, Blastomere biopsy, or trophectoderm biopsy, a DNA defect, such as single gene defect, chromosomal structural rearrangement, or an aneuploidy. So the aim is to identify an unaffected embryo and not to transfer an affected embryo, but potentially could generate a miscarriage or an affected child. So the technique has been difficult to set up, and we know that today the gold standard is trophectoderm biopsy and different genetic techniques. Why trophectoderm biopsy and not Blastomere biopsy? It's very important to know that when you perform a Blastomere biopsy, whatever is the aim, the genetic test that you want to do, you are reducing the implantation potential of the embryo. So this is why, as an embryologist, I need to highlight the fact that when we manipulate embryos, we have to be sure not to affect their potential. And today we know that Blastomere biopsy should not be performed. So let's come back to PGT as a test to identify an unaffected embryo. So it's one step in the embryo evaluation procedure. But embryo evaluation is not only for the 6 chromosomes. Embryo evaluation starts with the viability evaluation. First of all, before thinking about testing the DNA, we have to be sure that the embryo that we are testing or we are evaluating is viable. It means that it underwent diploid fertilization, the cleavage, and the blastulation. So this is very important. Only to reach the blastocyst stage, it's already a very important step in the embryo evaluation potential. Then you can move to the genetic testing and assess, for instance, the chromosome copy number, which is the aim of a PGT-A procedure. But this is not enough. We know that the embryo is like a puzzle, and viability and genetic, it's a lot. We can predict very well the implantation potential, but still embryos that are beautiful blastocysts and aneuploid may not implant. And we know very little about the competence, the capacity of the embryo to implant. And this is a biomarker that we have not in our lab, so we cannot really identify the implanting euploid blastocyst as compared to the non-implanting one. So let's go step by step, like the embryo. Okay, so blastocyst formation is essential, and blastocyst formation is quite low in human. You know, in an excellent good population of patients, out of 10 inseminated oocytes, only 4 as a mean will get to blastocyst. And if you move to a poor population of patients, such as advanced maternal age or severe malfactor, this percentage is even lower. Only 30% of the inseminated oocyte will be a blastocyst in advanced maternal age population, and even 20 in a very severe malfactor infertility, because 10 oocytes, as a mean 7 fertilize, and as a mean 3 or 4 get to the blastocyst stage. So this has to be very well known and has to be very well explained to the patient. Why is it so important to identify the blastocyst formation? Because this is a super important moment in the embryo development. It is the moment where there is the cell differentiation, when in the embryo you can recognize 2 different cell populations, which is the inner cell mass and the trophectoderm. So you can really assess the capacity of the embryo to differentiate, and this is a very important step for, of course, implantation. So now that we understand that to reach a blastocyst stage, it's much more effective in predicting implantation as compared to the cleavage stage. What is the implantation potential of these blastocysts? Untested blastocysts have a very different fate according to the patient population. As you can see here, very good prognosis population will have like about 35 to 40% possibility to a single blastocyst from this population has such a high implantation potential. But when you move to the advanced and poor prognosis population, advanced maternal age population, this percentage, this implantation potential is strongly lower, about 10%. And this is due to the impact of chromosome. Because what is the difference between a blastocyst, a beautiful blastocyst from a young patient population as compared to the advanced and maternal population? The difference is the euploidy potential. And it is clear, no debate on that euploidy is strongly related to maternal age. And you can understand it when you study oocyte or embryo, but also if you see women's fertility, and also if you look to the miscarriage rate according to female age. So why the miscarriage is increasing so fast with the advanced maternal age is because the embryo has a higher risk to be carrier of a chromosomal copy number abnormality. So should we go to blastocysts? Yes, of course, we need to culture the embryo up to the blastocyst stage. First of all, because the biopsy is not invasive, is not harmful when it's performed at the blastocyst stage. But also because the embryo that are not viable are in fact not useful for the patient. So it is very important to use all our biomarker to identify the right embryo, and also to know that an arrested embryo may also be euploid, as a beautiful blastocyst can be aneuploid. So these two different biomarkers needs to be combined. A single biomarker will not give a full picture of the embryo. We need to combine viability assessment and euploidy assessment. So blastocyst culture plus PGT-A if we want to know the copy number of the embryo. And is it enough to look to the copy number? Because the embryo, as we know, may be a combination of 2 or 3 different cell population that may have a different karyotype, and this is what we call mosaicism. So when we have a full monosomy or full trisomy, we can talk about aneuploidy, but sometimes we have something which is in between and could potentially be the mixture of normal and abnormal cell. So what about mosaicism? I'm not going to go through all the debate on mosaicism, but what is very important to notice is that mosaicism is independent from the indication from female age or for the infertility factor. And it's also independent from the ovarian reserve. It is something that is, I would say, physiological and in every patient population. It's not increased by infertility, it's not increased by maternal age. And what is also very important, and this is a poster that has won a prize at the ESHRE 2020, is that low ratio of mosaicism, lower than 50%, is in fact not affecting the reproduction fate of the embryo. Same implantation potential, same biochemical pregnancy, same miscarriage, same live birth, and no mosaicism reported in the baby born. So, mosaicism exists, but has a low impact in pregnancy. The real mosaicism in newborn is about 0.4, 0.3, and this is exactly the same in spontaneous conception and in infertility. So it seems to be a natural process that occurs in all the pregnancy. The problem, why shouldn't we care? We should not care about this? Because each time that we overestimated a mosaic embryo, we are going to remove that embryo to be transferred, and this is going, in fact, in turn, to reduce the pregnancy rate and the potential pregnancy for our patient. So we have to be sure that what we are testing is indicated in the population and is trustable enough to remove that embryo from the transfer. So in my view, euploidy testing is needed only to assess meiotic aneuploidies, the ones that are related to female age, the ones that are indicated in our population, in our infertile population affected mainly by advanced maternal age. And how to do it? Today we know we have a gold standard, we know which is the best procedure to do it. So blastocyst culture, biopsy, trophectoderm biopsy, vitrification, and single blastocyst transfer. All these steps are really very important to optimize the results. And I'm going to go through this because this is very important. As an embryologist, again, I have to underline that what we do in the lab can affect the quality of the PGT-A program. So, as we said, blastocyst biopsy and not cleavage stage biopsy, because blastocyst biopsy is not reducing the implantation potential of the embryo. But not all the biopsies are the same. It depends on the amount of cells that we are going to remove from the embryo. It's very important to know that the amount of cell and the moment in which we do the biopsy may affect the reduction in biomass reduction of the embryo. So we should wait the full expansion of the blastocysts. This has to be personalized. Each blastocyst has to be biopsied at the right moment. And the number of cells that needs to be removed should not extend 5 to 10 cells. Because when you go over, you risk to adversely impact the pregnancy outcome. So, timing of biopsy, number of cells, quality of the biopsy are very important factors. When everything is optimized, as in the laboratory of in the New Jersey of Dr. Richard Scott and his team, what you can obtain is beautiful results. And this is my preferred study. Looking to the predictive value of PGT-A at the blastocyst stage, not reporting low mosaicism rates. So it's a beautiful prospective blind and not selection study. And what they have transferred is embryo that were euploid and blastocysts that were aneuploid. And what they obtain in the euploid group is 70% clinical pregnancy with only 7% miscarriage. Same patient population, what they obtained by transferring aneuploid embryos is unfortunately 24% clinical pregnancy, but all end up in a miscarriage. So at the end, 0 aneuploid embryo, excluding mosaicism, were able to implant. So this is very important because this is clearly showing which is our positive and negative predictive value when assessing blastocyst formation viability plus PGT-A genetic. Now, how much is powerful this technique? This technique is really super powerful. I would never have believed that, like 10 years ago, that we would be able to predict as much implantation in all patient population. Because when you have a euploid blastocyst, you can have about 50 to 60% live birth in all patient population. Severe malfactor, advanced maternal age, or good prognosis patient. Still, the competence of these euploid embryos, and I think this is really very interesting and very new, can be affected by the age of a patient. As you can see, although the results are super good in all the group, the implantation, the clinical pregnancy, and the live birth is still better in a young good prognosis population as compared to the advanced maternal age, and probably there are other parameters that are affecting the competence of the euploid blastocyst, but as I told you, we are still looking what can really affect the euploid blastocyst implantation potential. So what is the power of this technology? It's not only to identify the best embryo and accelerate the moment where you obtain the pregnancy, but it's also safety. If you look to these 37-old women that performed the PGT-A in our group, she had an embryo, a beautiful embryo that was affected by a trisomy 21 that was not transferred. And also in the second case, we have dangerous embryos that of course may not implant or may end up in a very early miscarriage. But by doing this technology, we can avoid transferring dangerous embryos. And this is really very important in my view. But what should we explain to the patient? Should we explain that PGT-A is a miracle and they are going to get 50% pregnancy? Absolutely not. It's very important to understand that PGT-A is not a therapy. It's only a diagnosis test. So the number of babies are not increased by doing PGT-A. So if you have a cohort of embryos, let's say you have 10 embryos, which 3 are babies, 2 are miscarriages, and the rest are implantation failures or affected childs, by doing testing and testing, you're removing embryo, but the number of babies in your cohort is always the same. You are not adding useful embryos, you are removing bad embryos. And this is very important to underline and to explain to a patient. We are not fixing, we are just testing. And of course, in advanced maternal age, as you know, the rate of useful blastocysts, the ones that are going to give rise to a baby, are much lower as compared to the general population. So we're not fixing, we're testing. Removing abnormal embryo, increasing safety, but not introducing useful embryos and embryos that could increase the pregnancy rate. So in other words, we are significantly increasing efficiency. We can reduce miscarriage, we can improve implantation potential, we can do less transfer, we can then improve time to pregnancy, we can transfer 1 embryo at a time due to our incredible positive predictive value, but we cannot increase the cumulative live birth rate per cycle. We are not introducing, as I said, in our cohort, useful embryos. But efficiency is very important. Patients are looking for efficiency. I want to have my baby as soon as possible. I want to do my cycles in less time as possible. I want to invest less money. And of course, one of the debates regarding PGT-A is the cost effectiveness, because we know that the PGT-A is costly, but you transfer less embryos. And at the end of the story, there are nice papers showing that depending on the setting, but it's not sure that you increase cost, depending. It really depends on the patient population. So PGT-A is very important. And I think that the clinics are proposing this to the patient because it's so important what we are proposing to the patient. We are proposing to increase our positive predictive value. We are proposing to assess important potential malformation in the embryo. So we have to have an optimized technique because we are proposing adds-on. We have to be sure that these adds-on are not affecting or introducing false positive with a potential loss of embryo. And in fact, there is a high variability in euploidy rate among clinics, and this is clearly shown by different studies, but it depends on the expertise of the clinics. So it is important that when a clinic is introducing the technology, it has very strong KPI to be sure that the biopsy, for instance, is done in the right way. But what I would like really to understand, really to explain, is that the variability in euploidy rate is between centers is mainly due to the mosaicis reporting. More mosaic you report, less embryo will be available for patient, and this is very clear. So mosaicism, it's a very difficult aspect to deal with. what is for me very clear is that we have no indication to test mosaicism in our patient population. And because of a false positive, because of a different range of mosaicism reported, and because our technology itself could introduce false mosaicism, for instance, during laser shooting and biopsy, we should not. There is no indication and a very high possibility to do a wrong diagnosis. So for me, we should not report mosaicism, at least not, as according to our study, when it is lower than 50%. So let's go on saying that the quality of a biopsy and the quality of the interpretation of the data are really crucial in a PGT-A program. And we know that technology is very important because we did already a lot of mistakes when introducing PGT-A. We know that day-3 biopsy was not the best. We know that FISH was not accurate enough. Then we moved to RACGH, blastocyst biopsy, and now next generation sequencing. We are improving and improving continuously the technology, and this is really very important, and this is what happened normally in science. But now we have to look even further. To be sure not to affect the embryo, we may think about a new approach, which is the so-called non-invasive preimplantation genetic testing. So in that case, the aim is the same, but the method would change. Instead of doing a biopsy, we could just collect culture media because we know that the embryo, all the compartments of the embryo, are releasing DNA in the culture media. Beautiful idea. Because of the advancement in the genetic lab, we are able to nicely amplify culture media coming from day 5, day 6, or day 7 blastocysts, but we still have to validate the concordance between the culture media of a blastocyst and, for instance, the trifactor biopsy, which is our gold standard, no doubt. There are different studies in the literature with different results. So this technology is in a validation period. There are beautiful studies. For instance, Igenomix is conducting a fantastic multi-center study to confirm the results of our pilot study. I'm very proud to have been part of these studies. And in fact, we still have to optimize, although involving different centers, we are really able now to assess which is the expected concordance between the culture media, the trifactor and biopsy, but also the concordance between trifactoderm, biopsy, culture media, and inner cell mass DNA. And we are over between 80 and 90% concordance, which is really very interesting. Non-invasive, easier to be implemented, so very interesting for the future because it will be less costly and more accessible to all. So let's continue working to improve a technology that has an incredible potentiality, is to give to the patient a genetic information. So PGT-A cannot improve the IVF efficacy, but the aim is to, by giving a genetic information, to improve the efficiency, and especially the efficiency related to multiple pregnancy, because in PGT-A we are very comfortable with a single embryo transfer, but also, of course, the aim is to reduce miscarriage and abnormal pregnancy. It's a very early prenatal test. I strongly believe that patients should be informed about this possibility, especially depending on the patient age or the infertility factor. Patients should be able to also to refuse the test. Of course, they need to know about what is the predictive value of this test, and if you include mosaicism, you should clearly show to the patient which is the rate of false positive and false negative. Genetic counseling may be necessary. So it is a difficult procedure because it requires a lot of expertise in the lab, but also for consultation and to explain to the patient the real meaning of this technology. So this is why probably it needs to be done in reference lab that has underwent a specific educational program regarding the PGT-A procedure. So let's come back to our embryo. Of course, the dream of an embryologist would be to be able to assess so well the embryo, to be able to identify the one that is going to become a baby. And when there's a lot of claims that this technology is good, the other one is better, I think that the only way we have for embryo evaluation is to combine different technology, looking for different aspects of the embryo. The embryo is like an incredible puzzle, and we have to identify all the pieces to have a full picture. Starting from the viability, and this can be done by extending the culture up to the blastocyst stage. Then, of course, to assess the morphology. We know that there are some morphological aspects of the blastocyst and timing of development that can help us to better understand the quality of the blastocyst, and also make a genetic test, not only to identify the best embryo, but also to remove those embryos, like the one affected by trisomy, that may be even risky because they can implant, generate a miscarriage or an affected pregnancy. But this can be done only if you are in an optimized system. You cannot think to do all these things if you don't have an optimized culture system, but also an optimized biopsy procedure and vitrification procedure. Of course, the genetic lab also has to have an incredible expertise for the difficult tests that we are asking, and patients should be clearly informed about the real advantages and disadvantages of the technology, about the costs, and about in case that we have a positivity, patients should access to a genetic counseling to understand the results of the test that we have proposed. The future, I really believe that the future will simplify our work, because more the work is simple, more it is reproducible, standard, and effective. This is why I very look forward to the non-invasive approach, so the collection of the culture media for the genetic testing, which will really help the setting of PGT-A in different labs all across the world. And of course, this can only be combined with very high quality genetic lab that is going to help us in optimizing PGT-A. But the embryo alone is not a viable pregnancy. We still have to study a lot about why a euploid embryo is not implanting, and probably we have to look also to the other side of the coin, which is, of course, the endometrium. So there is still a lot to do. We should not estimate a euploid blastocyst. It's not enough to be a beautiful euploid blastocyst. It's already, I would say, half or two-thirds of the road, but we still have to work more to understand what is really necessary to be an implanting euploid blastocyst. So I would like to thank you for your attention and introduce you to all our team, and I'm very, very proud to have this incredible European network and all my colleagues. Thank you very much for your attention.
Dr. Rienzi, for your wonderful explanation and your walkthrough to the PGT-A. We know that it's really important to do it well, to do it properly, to analyze it in a proper way, and to train our people. And I guess that there's some questions in the audience. We have many questions offline. I would like to remind the people that it's online right now, live, that they can make it through the chat. They can make the questions, and we will reply it in 2-3 weeks, probably. But somebody here in the audience would like to make a question to Laura?
Can you hear me?
Yes.
Okay, perfect.
Dr. Rubio? Where's the microphone, please?
Hi, Laura. This is Carmen.
Hi, Carmen.
Many thanks for joining us today. Next time, in person here, and we will enjoy with you here. I would like to ask you two questions, one related to the clinical aspects, about what are the indications in your center, if you have any specific indications. And from the lab side, the other thing that struggles us is if you have a special criteria to decide which embryos to biopsy or not to biopsy, or a minimal number of blastocysts to go ahead with the biopsy, and what to do with these poor quality embryos or bad cases, because I know your experience with extending culture on day 7, and many people ask us about how are the results on day 7. So if you can share with us this, thank you.
Thank you, Carmen. I cannot see you, but I heard what you asked, and very nice questions. So I will start with the clinical part. So, you know, a prenatal genetic test should be, for me, accessible to all. It really depending on the will of the patient. So although it's clearly, PGT-A is clearly indicated in advanced maternal age, or in any case where you have a higher risk to have aneuploidies, basically in our center, all the patients are informed about this possibility. And of course, with a balanced counseling, they can decide to access to this treatment even according to their own will. I would say that in our center, the majority of advanced maternal age population is choosing for PGT-A, and a very low percentage of young patients under 35 ask for this test. But we inform all the patients about this possibility with a balanced counseling. So we are not pushing to do it, but we are informing that this can exist. About embryos, we are in Italy in a very special situation, because by law we are obliged to keep all the embryo in culture until they are degenerated. So this is why we have in the last years extended the culture even to day 7 and rescue a lot of bad quality blastocysts and slow growing blastocysts with surprisingly results. It is published on Reproduction, so there is a higher rate of aneuploidies related to poor quality blastocysts and slow growing blastocysts. So on day 7, or bad quality blastocysts have a higher aneuploidy rate, but still they can implant in a lower rate, but they can implant. So according to our law, we keep all the embryos, and we do biopsy and genetic testing on all viable embryos, even on day 7. And sometimes it's the only embryo, and we got pregnancy in patients that otherwise would never have access to the transfer. So now I would say that our philosophy is to be sure not to discard embryo that potentially, even with lower percentage, can give rise to a pregnancy. So we keep all the embryos, we diagnose all the embryos, and in case of euploidy, of course, we are going to make a prioritization. We transfer first the best looking embryo and the faster, that's no doubt, but sometimes we rescue also very poor quality blastocysts that maybe would never have expected, but they could generate a healthy pregnancy.
Thank you, Laura. Thank you.
Thank you very much, Dr. Rienzi. Anyone else? Dr. Josu Franco is going to ask your question.
Hi, Josu.
Hi, Laura. How are you? Thank you for your presentation. I have like 2 different questions. The first is, in the patients you have good prognosis, and are you implementing the no-invasive tests, or what is the cutoff of the age would you like to implement in the laboratory? This is one of the questions. And the second one was, you was speaking about the mosaicins, and you told us you didn't report the mosaicins less than 50%. But in these cases, for example, you can lose information in case you are going to transfer embryos and suddenly reduce the pregnancy rate, or you don't know what is happening, or you have any problem in the lab. You don't think you can lose information about it if, for example, the information between 40 and 50% of the aneuploid is mosaicins, and you don't know? These are the 2 questions.
So let's start with the first question. It's easier. So the first question is about non-invasive PGT-A for good prognosis patient. Look, in my view, non-invasive PGT-A in the future may be really the first approach for all. I mean, I really believe that with how fast the technology is going, we will be able to make an accurate diagnosis. I mean, I really hope that Carmen will continue to work so well, and I trust so much Igenomix team. But now we are already 80–90% able to have a concordance with the trophectoderm. It's so powerful to have an easy technique to be implemented in the lab. And easier it is, less mistake you do, and less damage you do to the embryo. So from being a doctor of the embryo, I mean, to have access to the DNA of the embryo without any manipulation is globally an incredible potentiality. So I'm really working hard to understand, together with Igenomix, how to make this technology accessible, and which will be really the positive predictive and negative predictive value. But I think that this technology will really surprise us in the near future, very near future. For the mosaicis, look, as I said, mosaicis is not indicated in the infertile population, not even in advanced and maternal age. I mean, the rate of mosaicis is the same in spontaneous pregnancy and infertile population. So if we don't have an indication, we should first think if we should introduce something that doesn't have really an indication in our population. It's clear that when I say that mosaicis should not be reported lower than 50%, it's also, of course, the expertise of a geneticist that is reading the output of NGS, because it's also depending on which chromosomes are involved, because if it's chromosome 21, probably the range will be different as compared if it's a chromosome that we know is not giving any kind of potential long-term damage on the baby. But the point here is it's not the information that we get, it's the potentiality to lose an embryo. Each time, I mean, the information that we get, I don't think that mosaicis is related to laboratory condition. I don't see evidence yet that there is any relationship between mosaicis and laboratory conditions. For me, it's more the interpretation of the data. It's more the technical artifact. It's the biopsy procedure itself that may influence the artifacts that are related to mosaicis. So because it's not an accurate diagnosis, it's not an accurate information that we receive. Not accurate because the lab is not accurate. It's not because the genetic lab is not accurate, but because there are some technical artifacts that may induce a non-precise estimation of the mosaicis. And because in pregnancy the impact is so low, I think that the risk is more to lose embryo than to get useful information.
Thank you very much, Dr. Rienzi. We do have one more question, time for one more question. If anybody, yes, please go ahead.
Hi, Laura, it's Nuno from Embryo Tools.
Hi, all my friends.
So thanks for your talk. And since we are discussing today the future of embryology, I'd like to hear your opinion on what would be the real future in terms of techniques or emergent techniques, still experimental, that might be useful in the future to treat these patients that there are no ways of having a euploid blastocyst, for example. Is there anything that you can do, that we'll be doing in the future to solve these problems that today seems that the conventional techniques are not able to offer a solution for these patients? Is there anything you see that we can do in the future? Thanks.
Yeah, no, it's a very, very important question. So I always say in the lab, look, we cannot fix anything in the lab. We are not improving the viability of the embryo by culturing in the lab. We are not improving the aneuploidy. What we can do in the lab to date, it's only eventually to reduce the competence of what we are growing if the lab has not good condition, and to test, but not to fix and not to make any therapy. So we really have to understand that the best lab in the world is only exploiting the potentiality of the oocyte of the sperm that is given by the patient. But we are not changing the thing. which is good in a way because we are not introducing differences, but in another way, it's poorly therapeutic. I mean, it's only diagnosis, but we do in the lab. So before thinking to be able to repair the embryo, means to push an embryo that would not get to blastocyst by giving something that will make a blastocyst, or pushing the embryo means that an embryo that has I would say an abnormal point mutation, and we're going to repair it. This is technically potentially possible. But my fear is that when we are going to change the fate of the embryo by introducing therapy, we have to be very aware that this could have long-term effect. So till now, we are very lucky. IVF is really introducing known or very poor long-term problems on the babies. If we think about therapies, this can be really different. So I would be very cautious with this kind of possibility. I would still think that the lab has to be optimized to fully exploit what we have, and therapy are really not so near in the future because of the potential long terms that this could introduce. So I'm more positive about the efficiency of the lab and less about the therapy that could be introduced. So till now, we need a lot of eggs to get the right embryo, and so we have to work with the clinician how to optimize the numbers and how to optimize in the lab the exploitation of the numbers that are given from the patients.
Thank you very much, Laura. So it looks like that Dr. Carlos Simon wanted to do the same question that Dr. Nuno Costa Borges did. So I guess that we are finalizing this session. Thank you very much again, Laura, for the wonderful lecture, for the Q&A session, and we hope to have you here in person for the next time. Thank you very much. We really appreciate it.
Me too. Thank you to Igenomix, Carlos, Carmen, and to everybody. Thank you.
Thank you.
Bye.